Chapter 6 of ICD-10-CM is for diseases of the nervous system. This presentation will cover the official ICD-10 guidelines specific to this chapter. There will also be clinical scenarios to practice coding what you just learned, followed by a small quiz at the end of the presentation. For each coding example, you will need to pause the webinar and use your ICD-10-CM coding manual to code the scenario. Once you resume the webinar, we will go over the correct codes, the rationale behind them, as well as how to locate them in the ICD-10 manual. Keep in mind that there may be more than one way to find a code. We are aware that there is a great deal of information contained in this presentation. Therefore, at any time during the webinar, please feel free to pause and replay as needed. It is important that you have already completed the Introduction to ICD-10-CM webinar, as you will use the conventions and general guidelines discussed in the introduction to complete the coding scenarios. As you can see on this slide, the codes for this chapter start with the letter G. If you remember from ICD-9, these codes all started with number 3. Also in ICD-9, this chapter included diseases of the eyes and ears. In ICD-10, these diseases were separated out into their own individual chapters. Another change from ICD-9 to ICD-10 is that the conditions listed on the slide have been moved from the circulatory system chapter in ICD-9 to the nervous system chapter in ICD-10. The authors of ICD-10 thought it was more clinically appropriate for these conditions to be part of the nervous system chapter. Another change is that the terminology for epilepsy has been updated with the following terms: localization-related idiopathic epilepsy, generalized idiopathic epilepsy, and special epileptic syndromes. There is an opportunity for greater specificity as the epilepsy can be further specified, such as seizures of localized onset, complex partial seizures, and intractable epilepsy. In ICD-10, the term intractable is the equivalent to the terms pharmacoresistant, treatment-resistant, refractory, or poorly controlled. Therefore, if any of these terms or phrases are present in the documentation, it would be appropriate to select a code for intractable in category G40 if the patient has epilepsy, or in category G43 for migraine. One of the new features of ICD-10 is the concept of laterality. In this chapter, laterality applies to hemiplegia coding. The ICD-10 codes for hemiplegia include the side of the body affected, as well as whether it is the patient's dominant or non-dominant side. If the affected side is documented, but documentation does not state if it is the patient's dominant or non-dominant side, the following is how you should code. If the left side is affected, but you don't know the patient's dominant side, the default for left is non-dominant. If the right side of the body is documented as being affected, but you don't know the patient's dominant side, the default is dominant. I think this all makes sense because most people are right-handed. Therefore, if the left side is affected, it's most likely the patient's non-dominant side. If documentation states that the patient is ambidextrous, your default code will always be dominant. Now let's try an example. Documentation states left-sided hemiplegia. How would you code this? Please pause the webinar to complete this example and then hit play to continue and learn the answer. The answer is G81.94, hemiplegia unspecified affecting left non-dominant side. To locate this code, you would go to hemiplegia in the alphabetic index. Since left non-dominant side is not listed, we must use the code associated with the main term, which is G81.9, with a checkbox indicating that more digits are required. When you go to subcategory G81.9 in the tabular, you have options for right dominant and non-dominant, and left dominant and non-dominant side. Since documentation states left-sided hemiplegia, but does not indicate the patient's dominant side, the default is left-sided non-dominant hemiplegia, which is G81.94. The next series of slides will focus on category G89, which is for pain not elsewhere classified. There are many guidelines for this category. The G89 codes may be used with codes from other chapters to further define a patient's pain as acute or chronic or neoplasm related. You would not use a G89 code unless documentation specifically states that the pain is acute, chronic, post-thoracotomy, or post-procedural or neoplasm related. Since pain is a symptom, a G89 code would not be used in place of the underlying diagnosis if it's known, unless the reason for the encounter is pain control and not management of the underlying condition that's causing the pain. If a patient with pain presents for a procedure to treat the underlying cause of the pain, such as spinal stenosis causing pain, you would only code the spinal stenosis. A code from category G89 would not be used. Conversely, if pain control is the reason for the visit, such as a patient coming in for a steroid injection for nerve impingement, a G89 code would go first, followed by the nerve impingement code. The typical rule of thumb is that the reason for the visit is the first listed code. It is also appropriate to list a G89 code first when the patient is admitted for insertion of a neurostimulator for pain control. If, however, the neurostimulator is inserted for pain control during an admission where the main reason for the admission was a procedure aimed at treating the underlying condition, such as nerve impingement would be coded first, followed by the G89 code. G89 codes can also be used with site-specific pain codes. For example, if a patient has acute neck pain due to a car accident, it would be appropriate to code both the neck pain, which is M54.2 for cervicalgia, along with G89.11, which is acute pain due to trauma. If the reason for the encounter on the previous slide with acute neck pain due to trauma is for pain control, sequence the codes as follows. G89.11 goes first for acute pain due to trauma, followed by M54.2 for cervicalgia. However, for this same patient, if the encounter is not for pain control or management and a related definitive diagnosis as to the reason for the pain has not been established, then the code for the site-specific pain would go first, followed by the G89 code. Moving on to post-op pain. The default for post-thoracotomy and other post-op pain not documented as acute or chronic would be the acute form. Typical post-op pain immediately following a surgery is not coded. Documentation would have to support atypical post-op pain in order for a G89 code to be used. Also, if the post-op pain can be associated with a specific post-op complication code, you would not use a G89 code. The post-op pain code is therefore to be used when the pain is not associated with a specific post-op complication. Otherwise, a complication code from Chapter 19, which is injury, poisoning, and certain other consequences of external causes, such as painful wire sutures, would be coded. It may also be appropriate to use a code for acute or chronic pain in addition to the complication code. Speaking of chronic pain, which is subcategory G89.2, there is no timeline for when pain becomes quote-unquote chronic pain. It is therefore up to the provider to decide and should be reflected in his or her documentation. Code G89.3, neoplasm-related pain, is used when documentation states that the patient is experiencing pain as a result of their malignancy, and is used for both acute and chronic pain. It should be the first listed code when documentation states that the reason for the visit is pain management. The neoplasm causing the pain would also be coded. However, If the reason for the visit is management of the neoplasm, and the patient also happens to have neoplasm-related pain, the neoplasm would be coded first, followed by G89.3 for the neoplasm-related pain. It would not be necessary to assign additional code for the site of the pain, as the neoplasm code is an anatomical code, such as breast cancer. The last thing I want to point out for category G89 is that central pain syndrome, which is G89.0, and chronic pain syndrome, which is G89.4, are both different from the term chronic pain, and therefore should only be coded when documentation specifically supports one of these conditions. Now I'd like to try some examples for this chapter. First, we have a 16-year-old female being seen for management of juvenile myoclonic epilepsy. The patient did not respond to treatment and was diagnosed with an intractable seizure. How would you code this? Please pause the webinar to complete this example and then hit play to continue and learn the answer. The answer is G40.B19, juvenile myoclonic epilepsy, intractable, without status epilepticus. To locate the code, start at epilepsy in the alphabetic index, and then locate juvenile myoclonic indented below. Indented under this is the term intractable, which is needed because documentation states that the patient had an intractable seizure. Under intractable, the options are with and without status epilepticus. Since documentation does not state that the patient has status epilepticus, the default is without, which points to G40.B19, which you would then confirm in the tabular. I also want to point out that since the fourth character of this code is a letter B and not a number, the alphabetic index tries to help point you in the right direction to find this code in the tabular by stating following G40.3. Sure enough, subcategories G40.A and G40.B are after category G40.3 in the tabular. Next, we have a pain example. This 38-year-old female patient has breast cancer of the right breast with multiple metastases to the liver. She is seen to control the severe acute pain of the liver metastases. How would you code this? Please pause the webinar to complete this example and then hit play to continue and learn the answer. Our first code is G89.3, neoplasm-related pain. Since the reason for the visit is for pain control, this code goes first. To obtain this code, locate pain in the alphabetic index, then go to due to malignancy indented below, which points to G89.3, which you would of course confirm in the tabular list. The next code is C78.7, secondary malignant neoplasm of liver and intrahepatic bile duct. This should be coded following the neoplasm-related pain code because the reason for the visit was pain related to the liver metastases. To find this code, go to the neoplasm table, which for the Optum 2015 ICD-10-CM Expert for Physicians starts on page 321. You would then locate liver, and since the cancer metastasized from the breast to the liver malignancy is considered a secondary malignancy, and the code in this column should be used, which is C78.7, which you would then confirm in the tabular. Our final code is C50.911, malignant neoplasm of unspecified site of right female breast. In the neoplasm table, look for the term breast. Since we only know that it is the right breast and right is not indented below the main term, we need to use C50.9, which is in the malignant primary column next to the main term of breast. The checkbox next to C50.9 indicates that more digits are required. When we go to the tabular, we know that the patient is female, so that category C50.91 is appropriate, and then our options are for right, left, and unspecified breast. Our final code is therefore C50.911 for malignant neoplasm of right female breast. Next, we have a patient admitted with a fever, stiff neck, chest pain, and nausea. A lumbar puncture was performed and results were positive for meningitis. Chest x-ray revealed pneumonia. Sputum cultures grew pneumococcus. The established diagnosis was pneumococcal meningitis and pneumococcal pneumonia. How would you code this? Please pause the webinar to complete this example and then hit play to continue and learn the answer. Our first code is G00.1 for pneumococcal meningitis. To find this code, first locate the term meningitis in the alphabetic index and then find the term pneumococcal indented below, which points to code G00.1, which you would then confirm in the tabular. The next code is J13, pneumonia due to Streptococcus pneumonia. To find this code, locate the term pneumonia in the alphabetic index and then find the term pneumococcal indented below, which points to code J13, which you then would confirm in the tabular. And also as a reminder, we do have some symptoms documented, but since we know what is causing those symptoms, we're not coding the symptoms, only the confirmed diagnoses. Next, we have a type 2 diabetic patient with neuropathy who developed weakness of the left arm and leg and was brought to the ED. It was determined that the patient had a TIA, which stands for transient ischemic attack. During this encounter, the patient also was treated for an intractable classical migraine. How would you code this? Please pause the webinar to complete this example and then hit play to continue and learn the answer. Our first code is G45.9, transient cerebral ischemic attack unspecified. To find this code, first locate the term attack in the alphabetic index, then find the phrase transient ischemic indented below, which points to code G45.9, which you would then confirm in the tabular. This code should be sequenced first because the patient was brought to the ED for the left-sided weakness. The next code is G43.119, migraine with aura, intractable, without status migrainosus. To find this code, first locate the term migraine in the alphabetic index, then find the term classical indented below, where you'll find a note which says C migraine with aura. You would therefore locate the term with and then aura under the main heading of migraine. We also know that the migraine is intractable, which points to code G43.119, which you would then confirm in the tabular. Our final code is E11.40, type 2 diabetes mellitus with diabetic neuropathy unspecified. To find this code, first locate the term diabetes in the alphabetic index, then find the phrase type 2 indented below. The next term to find is with, and then neuropathy indented below, which points to code E11.40, which you would then confirm in the tabular. This code should be sequenced after the TIA and the migraine because the TIA was the reason for the encounter, and since the patient's migraine was also treated, that would be coded after the TIA and before any chronic conditions the patient also happened to have, such as the diabetes. Our final example is a patient diagnosed with late-onset Alzheimer's disease with dementia and wandering. How would you code this? Please pause the webinar to complete this example and then hit play to continue and learn the answer. Our first code is G30.1, Alzheimer's disease with late onset. To find this code, first locate the term disease in the alphabetic index, then find Alzheimer's indented below, followed by the phrase late onset, and then finally with behavioral disturbance indented below this, as wandering is a behavioral disturbance. The codes listed are G30.1, followed by code F02.81 in brackets, which if you remember from the introduction to ICD-10-CM, the brackets indicate that this is a manifestation code and therefore can never be a code that's listed first. Our next step is to confirm G30.1 in the tabular. The next code is F02.81, dementia and other diseases classified elsewhere with behavioral disturbance, which we know comes next because it is the manifestation code following G30.1 in the alphabetic index. Also, the note at the beginning of category G30 for Alzheimer's states, use additional code to identify dementia with behavioral disturbance, which is F02.81. You would then confirm this in the tabular, and when you do, you actually have the final code, which is Z91.83, wandering in diseases classified elsewhere, as there is a note under F02.81, which states, use additional code, if applicable, to identify wandering in conditions classified elsewhere, which is Z91.83. And then, of course, you would confirm this in the tabular. Now it's time for our quiz. Our first question is, a patient is admitted with left side hemiplegia, but not specified as dominant or non-dominant. The default is. Our second question is, how is an encounter for pain management for acute neck pain from trauma coded? Our last question is true or false. There is no time frame defining when pain becomes chronic pain. You can pause the webinar to write down your answers and then hit play to find out if you were correct. The answer to our first question is non-dominant, as most people are not left-handed. The answer to the second question is G89.11, acute pain due to trauma, followed by M54.2 for cervicalgia. Remember that since the reason for the encounter is pain management, the G89 code goes first, followed by the site-specific pain code. The first code can be found by locating the term acute under the main term pain in the alphabetic index. Indented below acute is the phrase due to trauma, which points to G89.11, which you would then confirm in the tabular. M54.2 can also be found under the main term pain, and then you would locate the word neck, which points to M54.2, which you would then confirm in the tabular. Our third answer is true. There is no time frame for when pain becomes chronic pain. It is based on the provider's judgment. Remember, the United States will begin using ICD-10 on October 1st of 2015. After the October 1st compliance date, it will be very important to verify that claims are being received and to check remits for denials based on the ICD-10 conversion. This concludes Chapter 6 of ICD-10-CM, Diseases of the Nervous System. Please feel free to check out our webinars on all 21 chapters of ICD-10-CM. If you need further assistance with ICD-10 training for physicians and/or staff, please visit the VantagePoint website at www.vantagepointconsult.com or call us at 203-288-6860.